Okay, welcome everyone for it, and thank you for taking the time to join us tonight to attend this discussion on the anesthetic challenges related to same-day discharge after hip and knee replacement. So we are very excited to have you, and as I mentioned a bit earlier, the number of registrants is overwhelming, which really is a testimony of the interest there is into fast-tracking hip and knee replacement. This topic is probably more on your mind right now as we're dealing with a significant backlog of hip and knee replacement due to COVID situation. So let's all work together to palliate this situation on the long term. So this webinar would not have been possible without the financial support of the pre-Synthes, which is a part of Johnson & Johnson. So I really am really appreciative for your contribution. But I also would like to thank the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement, as they are the organization behind Enhanced Recovery Canada. They are the organization taking care of this webinar tonight. And you will hear more from them in the future as quality improvement goes hand in hand with these two federal organizations. So we talk about Enhanced Recovery Canada. Some of you may never have heard of this. This is an entity that started in 2018 by a group of dedicated healthcare providers that wanted to put ERAS on the map across Canada. So then with administrative partners, we joined forces and we've been working together since 2018. We've created the ERAS pathways, the Canadian ERAS pathways for colorectal. And right now, the gynae surgery pathways, as well as the hip and knee replacement pathway, are coming up and they will be completed within a few weeks. And we just started to work on the cesarean section pathway. So this is what Enhanced Recovery is. It's basically creating the foundation for better quality surgical care in moving forward. And who are our partners? Just to mention a few, basically the surgical or professional organization in Canada, such as the Canadian Association of General Surgeons, the Canadian Orthopedic Association, urology, we have obstetrician, gynecology, anesthesiologists are major partners with Enhanced Recovery Canada, but we also work with patients as they are always represented at the board, and help also from an administrative standpoint, we have the Royal College, who's a great supporter and provides some CME for to support basically the knowledge that are promoted with Enhanced Recovery Canada. Accreditation Canada is another partner. We have nurses, physiotherapists, dietitians, and so on, as well as provincial and regional health quality improvement organization. So we are there to create the foundation of quality improvement, and there's no better opportunity than tackling a topic that is quite novel to do outpatient hip and knee replacement. So we do, and you will see this when you receive all the information for hip and knee replacement. We have material dedicated to public, which is basically patient and family, providers, and also leaders that will help to fast track quality improvement. And here, this is just a representation of what we offer for colorectal, but you will receive what belongs to hip and knee replacement when it's finalized in the next few weeks. But basically, we have the pathway with references. We have tools for patients such as hard copies, but also animated videos that are in French and English, but the videos are also translated in more than 20 different languages. We work with Precare. It's a company in Montreal to be able to deliver this. So let's talk about anesthetic challenges to achieve same-day discharge hip and knee arthroplasty. So the program tonight will be led by four specialists. Dr. Vanditoli, who's the father, I would call him the father of ERAS for hip and knee replacement in Canada. And he will be joined by 3 anesthesiologists. They will cover the benefits and also of ERAS for hip and knee replacement, as well as the challenges that are met with our specialty anesthesia. So, and at the end, we're going to have a 20-minute discussion period. So I would invite you to have your questions, use the chat box, either for comments or for questions. As we have right now, we're close to 400 participants, so all the mics will be muted. At the same time, this webinar will be recorded and it will be available on the Enhanced Recovery Canada website in the coming week. So without further ado, I would like to invite Dr. Vanditoli to introduce himself and share his screen.
Okay. So thank you, Claude, for this great introduction and for your dedicated work as a president of Enhanced Recovery Canada. I think what you've done in Canada is tremendous and will help our patient to recover faster. I am an orthopedic surgeon working in Montreal. I'm a professor of surgery at University of Montreal. And I want to share with you my main interest over the last 5 years is really to improve our patient well-being and following the enhanced recovery after surgery principle. So as in the current pandemic period, we are all facing real challenges. We are asked to reduce hospital length of stay, reduce caregiver workload, minimize patient complication, and the risk of nosocomial infection. An ideal solution would be to implement an ERAS outpatient hip and knee program. If we want to continue or resuming elective hip and knee replacement, it is a unique opportunity for a change of traditions. I would invite you to read our paper on the topic in the next edition of the Canadian Journal of Surgery, which is the title is Combining Enhanced Recovery and Short Stay Protocol for Hip and Knee Joint Replacement, the Ideal Solution. If your main goal is to achieve outpatient surgery alone, this is quite easy. We can do cherry picking and select the patient who will leave home whatever we do, or we may rush the patient out of the hospital in a wheelchair with a pain pump and a big John's dressing. Doing so, we may increase the risk of complication, and for sure, we are not favoring patient engagement and satisfaction. The real ERAS objective is to improve the patient outcome to a level where he is ready to go home sooner and safely. We want to minimize the impact of our surgical procedure. To achieve our ERAS goals, we first need to address all the potential problems which may affect success. Pain, nausea, orthostatic hypotension, bladder retention, hematoma, wound problem, and loss of motor function are problems that need to be prevented. In 2015, developing our ERAS outpatient protocol, we reviewed the literature to find the highest scientific evidences for the effective interventions. Each problem may not occur in all patients, but we need to make the effort preventing all of them. Introducing new practices in the medical field is complex. Strong traditions exist. To make sure that all team members are on board, we created a systematic protocol like a recipe book that all caregivers need to follow very tightly. Our webinar tonight will focus on the anesthetic portion of the protocol. But keep in mind that a successful enhanced recovery after surgery outpatient protocol involves a change in practice from the first office visit to the home care. In the next week, Enhanced Recovery Canada will publish the clinical pathway for hip and knee replacement. This pathway is the fruit of 2 years of work and a consensus of more than 20 professionals across Canada. Okay, let's see the specific aspects of the protocol which are important for the anesthetist. First, we use a limited fasting protocol where the patient can eat solid food until 6 hours before surgery and can drink clear liquids up to 2 hours before the surgery time. We give a preemptive medication, including 1 gram of acetaminophen, Celebrex 400 milligram, Lyrica 150 milligram, scopolamine patch, aprepitant 125 milligram, and OxyContin, long-acting opioid 10 milligram. Then in the OR, we provide the patient with tranexamic acid, 1 gram IV, and dexamethasone 6 to 10 milligram is also given. The ideal anesthesia for orthopedic patient may be different than for other surgical procedures. It should minimize or avoid loss of motor function, avoid opioids and sedatives, and reduce postoperative orthostatic hypotension occurrence. When implementing our protocol in 2015 with my chief anesthetist and physiotherapist, we visited Dr. Berger's team in Chicago. His team developed a new anesthesia method meeting the ERAS goals. This technique is novel and breaks traditions. It is a multimodal technique combining epidural with deep sedation. It is opioid-free and maintains lower limb motor function during the whole procedure. I leave to my 3 other anesthetist colleagues to share their experience of the technique with you in their presentation later on. We did our first ERAS outpatient cases in 2016 with a within a structured clinical study. We compared the clinical result of our first 120 ERAS outpatient cases with 150 cases done in the previous year with a standard protocol. All interventions of our protocol are described in this open access paper if you want to do further reading. Our protocol was very successful. In addition to achieve early patient discharge, we obtained a 50% reduction of the adverse event rate in the enhanced recovery group. But we found unexpected finding during the post-op period. Patient recovery was way faster and above all expectations. I want to share with you 3 patient testimonies. All 3 patients presented had a previous joint replacement with a standard protocol and the other side with our ERAS outpatient protocol. Let's listen to their experience.
Madame Soulière, on vient de faire votre remplacement total de la hanche droite. On vient de finir il y a à peu près une quinzaine de minutes. Avez-vous de la douleur?
Non, pas du tout. C'est la deuxième hanche que Mme Soulière se fait remplacer. La première intervention était difficile, mais celle-ci se présente mieux.
Vous êtes capable de bouger la jambe? Montrez-nous, voir, faites plier comme il faut. Parfait. Le pied bouge bien. Vous n'avez pas de malaise, de... Est-ce que vous avez des nausées?
Non, du tout.
Du tout, hein?
Absolument rien. Voir un patient sourire après une chirurgie orthopédique peut surprendre.
On a fait le remplacement de votre hanche droite en chirurgie d'un jour avec une prothèse totale à double mobilité. Pouvez-vous me donner vos impressions? Comment avez-vous trouvé la différence entre les 2 opérations?
J'ai jamais eu mal. J'ai juste là, un inconfort un peu. Mais à part de ça, là, j'ai jamais eu mal.
Vous avez pris des médicaments pour la douleur?
Seulement qu'un Tylenol.
Combien de temps avez-vous utilisé la canne après l'opération?
Au max 2 jours.
Et qu'est-ce que vous avez fait 2 semaines après, le 24?
Le 24, j'étais au centre d'achat toute la journée. Et le lendemain, à mon chalet, j'avais 35 personnes.
Puis au niveau de la souplesse de vos hanches, trouvez-vous une différence entre les 2 côtés?
Ben oui, voyez-vous, je vous le montre.
Bien sûr, montrez-moi ça. Voilà.
La droite, c'est comme ça, là, celle qui vient d'être opérée, tandis que l'autre, a de la misère.
Okay. Donc, si vous aviez à refaire opérer une 3e hanche, qu'est-ce que vous feriez?
Ça serait la même chose que je viens d'avoir le 11 décembre. Ah,
So
oui.
this patient benefit very interestingly of her procedure. She had no pain. She was able to mobilize faster. She resumed her normal activity of daily living much faster. Let's see this other guy, which is a worker who had both hip replaced, and one with the standard procedure and the other one with the enhanced recovery protocol.
Vous avez été opéré à vos 2 hanches, la hanche gauche avec une procédure hospitalisée il y a quelques années, et la hanche droite en chirurgie d'un jour.
Après 3 semaines, j'étais allé en physio externe. Puis Puis cette physio-là, quand elle m'a vu, ben, elle était surprise. Elle pensait, c'était le 1er avril, elle pensait que je faisais un poisson d'avril. Ouais, elle trouvait que j'avais pas l'air de quelqu'un qui venait d'être opéré de la hanche.
OK.
Fait que, on a fait la session. Elle a dit, on va se revoir juste dans 15 jours.
Quel genre de travail vous faites dans la vie pour gagner votre vie?
Moi, je fais de la rénovation.
À 6 semaines, j'ai recommencé à travailler. Je fais de la rénovation, je faisais une salle de bain, j'étais en train de stripper une salle de bain à 6 semaines.
Stéphane Bernier, un travailleur de la construction, a récupéré très rapidement. C'est un autre des atouts du protocole, accélérer le retour à une vie normale.
Trouvez-vous que ça avait été aussi vite que ça pour la hanche gauche?
Non, la hanche gauche, à 8 semaines, je recommençais, mais vraiment travaux légers.
OK, parfait. Ben, merci beaucoup, M. Bernier.
So for this man, it was resuming work earlier. I mean, he was able to go back to his normal workload after 6 weeks, which is a major improvement versus his other hip, where it was delayed for more than 3 months. Then we have this guy who is a special character who sent us his own video, which all the editing.
Bon, on va faire du vélo 2 semaines après l'opération.
We have all kinds of character. Patients are just recovering faster. If you're an elderly woman, 70 years old, you will get some benefit. The middle-aged man, hard worker, or the sports person. So what we found with this protocol is that all the patient had they transferred us their testimony as they have a faster recovery. So we thought that we should take these subjective results and to explore them more scientifically. With a master student, Dr. Hardy, we assessed 48 patients who experienced both protocol, inpatient on one hip or knee and the ERAS outpatient on the other side. So the same patient, same surgeon, same implants, but a different perioperative protocol and anesthesia technique. Here we can see the result regarding the complication rate. As the previous study on the cohort, we found again a reduction by more than 50% of the adverse event during the post-op period. Most of the adverse events are grade 1, and as you can see here, the ERAS protocol was very effective, reducing the most frequent adverse event like pain, nausea, headache, anemia, dizziness, and hypotension as examples. It was also efficient to reduce grade 2 complication. We only saw 6% of grade 2 complication versus 25% in the standard inpatient group. Regarding pain level, it was relatively low and somewhat similar in the first 8 hours after surgery for both groups. However, the mean opioid consumption morphine milligram equivalence in the first 8 hours after surgery was significantly less in the ERAS group. Such reduction in opioid consumption will have a positive impact on its related side effects. Now let's have a look at the patient functional recovery. Patient walk and climb stairs without help significantly quicker, on average a full week quicker, which was statistically and clinically significant. They return quicker to their normal activity of daily living 1 week earlier and to sport activity 2 to 5 weeks earlier. Finally, they resume work approximately 2 weeks earlier. Such a faster recovery may have a significant societal and economical impact.
Ouais.
Regarding patient satisfaction, patients were significantly more satisfied with the ERAS procedure regarding time at the hospital, pain management, recovery, wound closing, and in general. In a Canadian public system where the patient have limited financial benefits to leave the hospital sooner, such results favor important patient engagement. When we asked the patient which protocol they preferred, either the standard inpatient versus the ERAS outpatient, they reported a clear preference for ERAS side with 85% versus 6% for the standard side. Compared to the standard inpatient care, our ERAS outpatient protocol proved to be safer with a reduction in complication of 50%, provides similar pain relief with less opioid in the acute postoperative period, better early functional outcomes were observed, and the most important, improved patient satisfaction. Results of this study highlight the importance of following ERAS principle when implementing an outpatient total knee or total hip arthroplasty program. All these results are great, but our team are still perplexed and not sure about the factors explaining such findings. In our study, both protocols were tested in the same patients, surgery done by the same surgeon, using the same surgical technique, same implants, and the same local anesthetic infiltration protocol. How can we explain the differences? We have 5 main differences between the standard inpatient and the outpatient ERAS. First, the use of aprepitant for nausea prevention on itself cannot explain the functional recovery difference. Dexamethasone may play a role, and it is an important factor in the ERAS protocol. Patient expectation and experience may be important, but we do not see such differences in other bilateral cases with the standard protocol. Last, it is the novel multimodal anesthesia technique. I truly believe that the anesthetists play a role, a very important role, in the protocol success. And honestly, I am a little shy and disappointed to admit that the impact of the anesthetist may be more important than optimization of my surgical technique. So it is time to leave the floor to the 3 anesthetist colleagues. They will share with you how you can play a crucial role in hip and knee patient recovery. Thank you very much.
Okay, so good evening, everyone. My name is Christian Hubert. I'm going to try to share my screen. So this is it. My name is Christian Hubert. I'm an anesthesiologist at Maisonneuve-Rosemont Hospital, and I'm a clinical associate professor at Montreal University. I'm a colleague of Pascal-André Venditoli, and I have the honor, well, first of all, thank you very much for the invitation for this webinar. I also have the honor to be the first anesthesiologist to perform anesthesia, this novel technique, on the first patient who had outpatient hip replacement surgery in Canada. So this is where my experience started with this group, and I had the chance to perform a lot of anesthesia over the last 4 or 5 years. And tonight, I like the word recipe book. I'm really gonna explain tonight how we do it in Maisonneuve-Rosemont. I'm gonna teach you, or at least show you, the original protocol that was implemented in Maisonneuve-Rosemont Hospital. I have to say that this protocol has been largely inspired by the protocol from Chicago Hospital. And I can see in the chat box that there are a lot of questions about specific items in the protocol. There's some different level of evidence to support, or more or less, each item. But I will not discuss them because of time constraint. That's the first thing. And the second thing is that this protocol really works well. So I would just invite people that would like to challenge every item of this, the protocol, if they want to do so, to measure what they're doing rather than just doing it and hopefully think that it's going to be working. So without further ado, let's go in. I just want to say that I have no interest to disclose. So just a slice of life. About 4 or 5 years ago, I was at the OR, and my chief anesthesiologist back then, Dr. Fortier, came to me one day and he said, Christian, I went with Dr. Venditoli to visit Richard Berger's team at the Rush Presbyterian Hospital in Chicago. And he told me what I saw was absolutely, truly mind-blowing. They were doing 9 total hip replacement per day. All patients had an epidural. And the epidural only had lidocaine, nothing else. They had high dose of propofol, between 100 to 125 mics per kilo per minute of propofol. They received no benzodiazepine, no opioids. And the first patient at noon was walking, was eating a sandwich. At 3 p.m., he was discharged and had no pain. And so he said, we want to implement this at the Maison de Rosemont Hospital. So like Pascal told you already, there are several goals, I would say, in a ERAS protocol, and the anesthesia has a great part for total hip replacement surgery in an outpatient basis. And the goals of our protocol are on three aspects. It's really to avoid motor block, to avoid hypertension or to static hypertension more specifically, and avoid nausea. Because these three factors seem to be really the limitation to a fast recovery and a rapid discharge from hospital with a satisfied patient. So first thing, as we discussed already, all patients about an hour before the surgery receive aprepitant, which is an inhibitor of neurokinin receptor 1. They all receive dexamethasone between 4 and 6 milligram intravenously. And they also have a patch of scopolamine. The patch of scopolamine, we reproduce what was done in Chicago. I know that I do appreciate that there are some contraindications and then there are some side effects. And for the patch of scopolamine, we tell patients that if they cannot tolerate it, they just remove it. It won't make much a big difference. But if they tolerate it well, we recommend that they keep it behind their ear for about 2 to 3 days. We do not administer prophylactically ondansetron. We give it only for treatment of nausea. Same for metoclopramide. All patients, as Pascal said, receive tranexamic acid, and they receive IV antibiotics as per protocol. As soon as the patient enters and the IV line is put in, we start the propofol infusion at 50 mics per kilo per minute. Meanwhile, we put the patch of scopolamine, we install the monitoring, and we install ourselves for the epidural. I don't give bolus at that time. The patient do not need bolus of propofol. The sedation is slowly installing itself, I would say. We do not give IV opioids at all, and we do not give benzodiazepine neither. So at the beginning, when we implemented the protocol, some colleagues and I myself were a bit shy not to give any benzodiazepine. So some people gave midazolam intravenously to perform the epidural. And we had quite a few failures of rapid discharge because the patients were too drowsy or too much sedated at the PACU. So from then on, we only decided to limit the sedation to propofol for the epidural placement. Then the second thing is the epidural. So we perform an epidural, and there's been a lot of conflicting messages about the level of the epidural. So the epidural is done at the lumbar level, okay? Because this is the core of the anesthesia of the surgery stimulation. This is where we want to anesthetize the patient the most. So we do a lumbar epidural, but we aim for a sensitive block to cold at up to T10 more or less, okay? So I want to focus here on the sensitive aspect of the epidural because we don't want to have a big motor block. We don't need a big motor block. We want the patient to recover rapidly after the surgery and walk rapidly after the surgery. So what we need is a patient who will not have pain during the surgery and will not need narcotics or opioids during the surgery. So when you do the epidural, we give a test dose of 2% lidocaine with epinephrine, 5 mics per cc, so the standard 3 cc test dose. And then we give lidocaine 2% 10 milliliters. So basically, all patients will receive 260 milligrams of lidocaine. Rarely, we need to inject a little bit more lidocaine, but most of patients will be anesthetized with this. And I want to reassess again that we're looking for a sensitive block. So you test the block with cold, and when the patient starts feeling that there's a significant reduction in cold sensation, it doesn't have to be a complete sensitive block, but that you know and you're convinced that the block is installing itself, we're ready for the surgery. You don't put opioids in the epidural. You don't need to put adjuvants in the epidural. No epinephrine. Don't need to put bicarbonates neither. Just lidocaine. If the patient has a contraindication to epidural or has a failure of the epidural, that is, like, you're not convinced that the sensory block is installing convincingly on the surgical side, then you're better off just proposing a general anesthesia only with propofol and remifentanil. We tend to do more often epidurals, and we like to do the epidural more, probably because the patients still recover a little bit better at the PACU and in the outpatient ward. In my experience, I had to do 3 general anesthesia, one for a patient who was presenting with spinal stenosis, and we decided not to do an epidural, and for 2 patients who did not have like a convincing sensory block installing, and we performed general anesthesia with propofol and remifentanil, and all 3 patients were able to be discharged the same day. Or they were happy, they recovered well, but it delayed a little bit the whole recovery during the day because they were a bit more drowsy. One was a bit more nauseous. So it's not the technique that we propose on first line, but it's not a failure for the outpatient ERAS protocol if you decide to do general anesthesia. Just to show you here that we don't look for a motor block, you can see here that the patient has been turned on the side, the epidural is done, and we're ready, we call the surgeon, we're ready to do the surgery, but the patient can still move his leg. There's some motor block that is installed, but you cannot guarantee that the motor block will be complete during the surgery, and we are not looking for that. We are only looking for the sensitive block. Once you call the surgeon, which will be typically between 5 and 10 minutes after you have injected the 10 cc dose of lidocaine 2% in most of the patient, then you increase the propofol infusion rate to 120 mics per kilo per minute, and this will be only for about 10 minutes, 15 minutes, and then you're going to start tapering down the rate to have a rate between typically 40 to 70 mics per kilo per minute during the surgery. Now, patients are very different, and there is a wide variation in the dose of propofol. Some patients will only need 20 mics per kilo per minute, while others will need 100 to 120 mics per kilo per minute. But what you're looking for is a patient that is completely asleep and has no contact with its environment. And why is this? Is because you have provided with the epidural a sensory block. So the patient will not have pain, but the patient could still have proprioception. The patient could still be disturbed by the sounds, by the vibration, by the movement, and might be reacting and contracting its muscles. And that is not, this will not provide good surgical conditions. So you need the patient to be not reacting to its environment, right? So this is why you need to give high dose of propofol. At Maisonneuve Rosemont Hospital, we have nasal prongs with capnography. So it helps us to monitor breathing. You, of course, want the patient to keep on breathing. You don't want to have a patient which is in apnea. And so sometimes you will need to use oral or nasopharyngeal airways. For hip replacement surgery, I seldom need them because the patient are put on the lateral position and they rarely have airway obstruction. Some do, but not all of them. For the knee replacement surgery, that's another story. All patients are in supine position, so they all have like airway obstruction. And so most of them, almost all patients, I do a lidocaine nasal spray, and I put a nasopharyngeal airway, a 28 French or 30 French device. And then the propofol is continued throughout the surgery until we are at closing the last muscle layers or the skin closure. If the patient is reacting during the surgery, it is most likely because the sedation is not strong enough and the patient is disturbed by the situation. And I'm pretty sure about this when I do my patients, because I had a good sensory block that was installing when I started the surgery. If you did not have a good sensory block, then it could be pain. And if you give narcotics during the surgery, the patient will stop breathing. So you do not want to give narcotics. So you need to start the surgery knowing that your patient will not have pain by the means of the epidural. If the patient reacts, then it's most likely because the patient is not sedated enough. I give a bolus of 10 milligrams, so 1 milliliter at a time of propofol. I will sometimes increase the infusion by a rate of 5 to 10 mics per kilo per minute, and I will see how the patient is behaving with this. Not quite often, but not that rarely either. I consider and I give ketamine, about 0.25 to 0.5 milligrams per kilo IV push as a bolus. We like this medication because it keeps the respiratory drive. It has a little analgesic effect as well. So in doubt, if you think that your patient might still be in pain, you might consider ketamine, but you should not give opioids or benzodiazepine because you increase your risk to have a patient who will present with apnea. All patients at those doses will have some degree of hypertension, so do not hesitate. Use any vasopressor of choice to maintain blood pressure within your acceptable range. So you can see in the background a patient who is 62 years old, has had dyslipidemia, hypertension, diabetes, and sleep apnea. And as you can see, we will follow through the protocol with this patient. As soon as the patient is turned on the side, I already started reducing the rate of propofol to 100 mics per kilo per minute. Once we're prepping the leg of the patient, already with this patient, you could see I reduced the rate to 75 mics per kilo per minute. At that point, during the surgery, the sensory block is not necessarily completely installed. And very, very often, this is very often, almost all the patients, they will still react a little bit, have a little bit, some degree of pain when you lift the leg. That is because the sensory block is not fully installed and because the sedation is not necessarily completely up to par. The patient is still reacting a little bit. But if you had a good sensory block installing when you tested your epidural before calling the surgical team, at skin incision, the patient will not react. So as you can see here, we're at 75 mics per kilo per minute. And at skin incision, we are at 60 mics per kilo per minute. So I just wanted to eliminate the myth that all patients throughout the whole surgery are receiving absolutely on a mandatory basis, infusion rate of 100 to 125 mics per kilo per minute of propofol. This is not true. Most of the patient will be running between 40 and 70 mics per kilo per minute. Here again, a little video just to show you that the patient is sleeping. We're well into the surgery. Actually, we're about 25 minutes into not into the surgery, 25 minutes from the time that I injected the lidocaine in the catheter. And you can see that the patient is sleeping well with 60 mics per kilo per minute of propofol. Even further during the surgery, I was able with this patient to reduce the rate to 50 mics per kilo per minute. And you will see here that despite stimulating surgical procedure with a lot of noise, vibration, with 50 mics per kilo per minute, the patient is not reacting. There's no pain. There's no pain. The patient just needs to be sleeping so that he does not react and start moving during this procedure. But as you can see, it's going on and going on. There is noise and there's a patient that is not reacting. And at that point, if sometimes patient react, 10 milligram of propofol, increase the rate of 5 to 10 mics per kilo per minute. And for many patients, this works well. I will continue. Sorry, I'm just trying to move. Okay. Once the surgery is finished and you have stopped the propofol, now it's time to go back to the PACU. You remove the catheter, the epidural catheter, in the OR. The patient doesn't go to the PACU with his catheter, doesn't go to the outpatient ward with his catheter. It is removed in the OR. In the PACU, we really try to so we offer analgesia on a PRN basis, really on a per request basis. There's nothing that is mandatory. I have not written it there on the slide, but there has been an infiltration with ropivacaine and ketorolac in the wound by the surgeon. And most patients, and we also push forward oral analgesia rather than parenteral analgesia. So if we need to go to parenteral analgesia, it will be subcutaneous or IV, but this is really at the last line of analgesia. Now, one of the most controversial aspect of the protocol, as much from the anesthesiologist and the surgeon, is the placement of an intra-articular catheter. So in our protocol, there is an intra-articular catheter for knee surgeries. And if there is a catheter, we inject ropivacaine in the catheter the next morning before removing the catheter. And that's it. I will finish my talk just by showing you a patient, our patient, I remind you, 62 years old, hypertension, diabetes, sleep apnea, and dyslipidemia. And this is 1.5 hours after the surgery in the outpatient ward. And the patient is walking with a cane, has no pain, ate his sandwich, and was able to be discharged from the hospital a bit later during in the afternoon. So that's it. This is the protocol. I'm just gonna let you enjoy a little bit this patient, even being able to turn around and walking very freely and nicely. So I will be very happy to answer questions at the end of the talk. And I guess there's gonna be a few. And from now on, I'm gonna pass the mic to Dr. Avinash Sinha. Thank you.
Thank you, Christian. That's a fantastic talk. I hope you can all see me. I turn my camera on. I will join you briefly when I share my screen. I think we can all agree this is a fantastic result achieved by experts who have researched this and devised their technique over time and through the approach of other experts, and collated a lot of experience into this and achieved excellent results. I would just like to begin by making a brief acknowledgement of the current crisis that we're all in and the suffering that it's caused. All of our colleagues who are experiencing the loss of loved ones and perhaps even livelihoods, our teams are adjusting to our new reality, or reeling from the infamous 2020. In this context, proposing change needs to be acknowledged. This needs to be acknowledged, and this begins with our forming and reinforcing of relationships. We are challenging beliefs, needs, and often hidden assumptions about what might be safe or even effective. And it's appearing in the questioning that it's in the chat box, and I completely acknowledge that, and I've experienced this myself when bringing this protocol to my institution. Data can only go so far. Addressing what can be closely held beliefs is a challenge. But in times of societal stress, we engage in habits and routines that within which we feel secure. Today, we are challenging these. The leader as a host is an aspirational approach to provide the environment where others may achieve, while in the end recognizing their achievements as self-delivered. For this, we need to build a team. The mindfulness of this approach, I think, is important to just place at the beginning of this talk. And through this lens, please see and hear what I'm going to present. When we are in a stress zone, we tend to stick to old habits and patterns of belief, and we may need to move through a self-awareness sort of approach in engaging with our team members and our colleagues in a truly multidisciplinary environment to see what new ideas can come and how we may bring a fulfillment for all of the people involved, not just driving a protocol. So into the implementation process overview, this is just to say all of the slides I'm going to talk about will be summarized here in this one slide. We need to generate a team. The team involves a senior stakeholder, that someone with reputation and who's recognizable. This person can provide quasi-institutional mandate, a lead physician, someone who's a clinical champion that is going to take a personal interest, much like Pascal has and Christian has in partnership with him. They went to Rush in Chicago to see what another clinical champion had done and collated all of that. So what do we do in our institutions? I would suggest we engage in a discussion, an initiative perhaps, in optimization of delivery of care, where we look at our status quo and we see where our confirmation biases are. To do that, of course, initially, as I said, we need to create the environment where such discussions can take place. We're often going to come up against, if it ain't broke, don't fix it responses. And to enhance institutional efficiency and to improve patient outcomes seems to be an obvious goal. But our institutional resources under pressure, we could easily prove the benefit of this. But in the 3 years of the implementation that we've been going through, that had to take place on the basis of 12 years of foundational work that I did to generate the reputation that I could bring this idea. Timelines and expectations, I must admit, I placed upon myself were naively inappropriate. And there's a lot of self-management and reputation building that I sought to do, essentially to influence people and to create sustainable progress. The process of trust generation and allowing people to feel safe enough to contribute or imagine potential solutions is I think, pivotal. It cannot be ignored, however. We find ourselves in a unique moment in history where everything we have come to a stop, and now we have the opportunity to restart and reimagine in that way. With all the challenges that have precipitated fear and the need to control, the opportunities to reimagine and pivot and evolve seem more accessible. However, the process is important. Perhaps a secondary implementation process where we can trial the process, collect data, show that we are achieving results. And I've done this with various other areas where we can show dischargeability before we create the day surgery protocol. This is a phased introduction rather than a radical practice change, which can be met with resistance. And it's perhaps a way of imagining this. In a post-COVID era, we will and we are needing to make resource utilization all the more efficient. But in this, we may prepare to lead. If not, we may need to follow. The data is out there. And as I said, data may sometimes not be enough. But there's a great deal of interest in this, as your presence in this webinar proves. The focus on a quadruple aim, population health, as Pascal and Christian pointed out, the population is changing, the patient's needs are changing, the patient and the provider's experience. the return to work and the efficacy of the surgery for the patient's outcome, but also the satisfaction for the provider. And finally, of course, the affordability. Save one day in hospital, the institution will tend to thank you. However, doing this, as Christiane says, clear metrics, measure what you're doing. Quality, safety, patient experience cannot be diminished in its importance. The testimonials in the videos we've seen are clear. The estimation of about 1 million joint replacements a year in the USA, only 5% seem to be day surgery at this time. And by 2040, excuse me, the demand is to increase by significant multiples, 2 to 3 to 4 times what we're doing now. So maybe a practice change is due. This requires leadership at all levels and perhaps a wholesale shift in surgical practice, where eventually we get to an opt-out approach where all patients are done as day surgeries and those that are more medically infirm would opt out. Clearly, the focus on anesthesia is the same as it seems to be always the case. Minimize pain, minimize postoperative nausea and vomiting, allow for immediate mobilization, I think is key, and minimize postural hypotension. However, this is done in Pascal and Christiane's protocol in a very specific way, addressing each element separately. We will address some of the elements of the recipe, I think, from the questions that I've seen. There is some response to some questions that we would like to give. But as all of this translates into a pathway, a corridor of care, one might ask, how would you go about designing such a thing? Well, this is sort of a nuts and bolts, pharmacological potential targets, elements that we could use to treat. But I think is what is, and of course, we're going from a neuraxial approach to a plexus approach to a nerve approach to a joint approach. Now, being more and more selective to the area of surgery is just as a design to perhaps follow in your discussions. But the other point I wanted to focus on is the non-pharmacological, the preemptive psychoeducation is not insignificant, as Pascal had said, from the beginning of the booking, from the first meeting in clinic, from the setting of expectations. These are all elements to the protocol. The experiences, again, recently published of pre-post information in a massive cohort from the Danish experience, they identify these 5 points. Support in the decision to have surgery. The uncertainty in the whole experience is replaced by confidence when prepared for surgery. Prerequisites for feeling secure before discharge. Am I safe to go home? Rehabilitation at home. Will I be able to do this on my own? Unmet expectations need to be met, and the assistance to accept the realities seem not to be a problem for the sporting patients of Pascal, but the elderly, the less independent, perhaps need more psycho support in this regard. And we find that we achieve that with a lot of patient information, booklets, pre-preparation, delivering the booklet very early and allowing them, in fact, asking them if they've studied their booklet. And they often come in proudly holding the booklet going, yes, I've read every page. And that's really comforting, and it really brings the patient and the care provider into the same corridor of care. In these the challenges to these implementations, it's likely to meet resistance. And in leveraging local rivalry, as we did between McGill and University of Montreal, the French and English side, we can sort of say, they can do it, so we can do it. But some people will reply by saying, just because they do it doesn't mean it will work for us. We don't need to change practice. If it ain't broke, don't fix it. And sometimes that's very disheartening. And it was for me. But I realized you invite the critic to speak. You let them have the floor. You allow them to potentially illuminate a blind spot for yourself, or allow that person to have a voice and potentially create an ally. And you seek a win-win solution. Biases are inherent. status quo bias, it is the way it is, it works fine, or a confirmation bias. I've seen it done like this, I want to do it like that. So you have both extremes. In this implementation phase, it is stressful because every failure seems like a critical moment, but each moment can be an iterative process of learning and refinement. The early adopters will create a pull of curiosity. People will look into my room and say, oh, what's going on here? Your patient's already up and out. They're walking in recovery. What's going on here? They will be intrigued. And I was intrigued when I went to visit Pascal and Christian. And it is fascinating, as they were intrigued when they visited Chicago. So I think that's pay it forward or pass it forward. Also, people say that, you know, and even today I was working with a surgeon and saying, oh, these patients don't need this surgery. We're doing younger and younger patients who maybe the surgery is unnecessary. That's hard for me to say, but it's definitely a response that you might get. In this post-COVID era, we are being asked to return to surgery with a sense of urgency and a sense of pressure. And I remind you, our teams have been put under strain for quite some time, and returning to working even harder is going to be difficult without people's buy-in, without people's engagement, without people's sense of satisfaction to the part they've played in something tangible. We just did the first day surgery sports orthopedics list today that we've done in a month or two. And it was incredibly satisfying for the people around. It's not the same as doing extremely sick people who are going to take up hospital resources and require an ICU bed for a week. And it was really tangible to see how everybody's day went, and they had a really good experience. So the provider experience, I think, is more and more important as we come out of this crisis. And if we are to lead, if we don't lead, we will need to follow. We did inclusion criteria, which were simplified, but we are now thinking of exclusion criteria as we progress in our implementation. The severe exclusion criteria will obviously be the elderly and the infirm who are not medically well. There are recent studies that look at which particular comorbidities are more likely to cause side effects or post-operative care issues, and diabetes, insulin dependent particularly, is one of them. So we have to be careful in our patient selection. I think that's the message. And our lessons learned. We need to clarify our inclusion criteria. We need to develop systems within the hospital so that our medications can be delivered pre-mixed, as it were, the infiltration solutions. We did go through a process of engagement with the pharmacy, and they do provide that for us now, but we are creating work for them, but they are generating an outcome for us. So that partnership is very, very key, very key. The early pain on arrival to PSU that we observed was because we weren't doing adequate deep layer infiltration with local anesthetic. And so we were learning iteratively as we were doing it. In every case, I would feed back to the surgeon, I would come back and feed back to the surgeon. And as that, in that open process of collaborative discussion, we learned from ourselves. And patient testimonials can be very powerful, as Pascal and Christian have shown. Mine is not quite so impressive, but this is an retired orthopedic surgeon from our department who had his hip done. And so he wanted to show us how well he was walking the next morning. And not to be outdone, he sends us a second video where he does it without his cane, just to show off. Typical orthopedic surgeon. Very, very, very capable, very nice guy, and we were happy to help him. And he already had a previous hip on the other side by the previous protocol. So I pass over now to my friend and colleague, Jacques Smith from Victoria, who has also had extensive experience in the implementation of this protocol. And I look forward to hearing his thoughts.
Thank you, Avi. Thank you for getting me involved here. Let's hope this works. All right. Well, thanks everybody. Thanks for having me. And greetings from Victoria, from the island. It's been a nice day. Nice and warm outside. There's no snow. There's no rain. But yes, thanks for inviting me. And I thought I'd share some experiences that we had in Victoria with implementation of our same-day arthroplasty program, as well as enhanced recovery principles and bringing that to Victoria. Not to be outdone by Avi and the Christian, and here's my experience. So this patient on the left here, she's still on the operating room bed, and she has had her knee replacement.
Thank you.
And there on the right, she's just completing physiotherapy prior to discharge, and that is about 4 hours after the surgery. And she continued to do very well and was very satisfied. So my topic today is to talk a little bit about some of the barriers that you might experience with implementation, and certainly some of the barriers that we had to overcome to bring same-day arthroplasty, but enhanced recovery principles to Victoria. And just for some context, Victoria is a tertiary referral hospital for the island. But we're not a tertiary center per se with residents and dedicated residents or clerical support. We don't have research support. All of this was done through some grassroots level with myself and our orthopedic team and then the extended team that came along. We're one singular anesthetic department that provides service to 2 hospitals. And all the anesthesiologists do rotate through the joint replacement room. Now, in about 2016, 17, 18, Victoria was blessed with the longest waiting period, I think, in the country per capita. And this led to some significant political, but also local institutional pressure to change the way we were doing business, to try to improve our efficiencies and try to get to those waiting lists. And it obviously involves significant resource allocation and reallocation. But this is how we got involved with this process, is trying to look at all the options of improving efficiencies and outcomes. And so when it came to changing some people's practices and our own practices, as Avi mentioned, and I also noticed in some of the text, the messages, is that there's so many barriers to reasons why we would change. We build up these reticence to change over many years, and we try and test methods, and we try to control the variables in the OR. That's what we spend a whole day doing. And in that, we try to create a much more stable environment for the patient and for ourselves. But, we build up these superstitions and biases over many years, and we perfect them. And when we ask people to change after creating so much certainty for yourself, it's very almost unreasonable. And it takes a lot of effort and also a lot of commitment and willingness to change. And then it comes to this sort of leadership cliche almost. And I do want to note that I'm not in a leadership position within the governance of our hospital or in our anesthesia group. And I got involved because I had a keen interest in regional anesthesia, and I have some relationships with the orthopedic surgeons outside of work. We play tennis and do music together, etc. But it comes down to these little drop-down menus in terms of implementation. And these were not a strategy that I followed or that we followed, but it ended up being the strategy that actually worked. And I'm taking a bit of a roundabout method in discussing about the barriers and overcoming them, because in hindsight, preventing barriers is actually just as effective as managing and getting through barriers. And where we started was, I think it started with a little bit of curiosity and enthusiasm. And obviously, as I mentioned earlier, some pressure at looking at some of our metrics of how could we improve our efficiencies and use our resources to the maximum. And I think any such program, if you're interested in this, should really start with getting a like-minded orthopedic colleague if you're an anesthesia, and similarly the other way around if you're an orthopedic surgeon joining in. I think that both parties need to be have a good relationship, a good working relationship, and the enthusiasm to try something new and to try to work within your system and be open to change. And I think it really just starts with that collaboration. And I think starting to beg is probably not always the best thing, because everybody wants to throw in their little bits to make to keep their biases intact. I think this slide is kind of confusing, but and I apologize for that, but I think it's actually the most important part of implementation and preventing barriers. When I got the protocol from Montreal, just like some of these messages in the box, I didn't believe it. I had my own bias against it. I didn't agree with it, but I saw it firsthand. And what happened was I realized that this thing is bigger than just following a recipe. And I think that this is really important, because if you are planning to implement one of these protocols, it's so important to understand your local context and to build the protocol into the matrix, because that's what we did. Simple things like aprepitant, it's not on formulary in British Columbia. They took it off for post-operative nausea and vomiting. And so how do you implement those protocols? The only way you can do that is to totally understand your local institution and my local institution. And we did that through significant discussion and collaboration with orthopedics. And I think it's really important as an anesthesiologist to understand how patients are booked. What does their care package even look like? Read the booklet. Get to know and talk to the nurses in recovery room and also on the floor. The most valuable information that I got was from speaking to nurses and physiotherapists and finding out what was working and what wasn't working and how could we make these changes. Because on our own, just slapping in a protocol, it just doesn't work. And you'll get so much resistance unless you can totally understand the matrix of your institution and then bring them all in. And that's what we ended up doing. And I think we started in a small way, and I promise you this thing gets big. It turns into something that almost just gets its own steam. And the reason I say start small within, and by that I mean is starting with one surgeon, one anesthesiologist, or maybe smaller systems like 2 and 2 or 3 and 3, is that it's much easier to make dynamic changes as you go when you start implementing these changes. If it's too big, it's almost much harder. There's too many players involved. And it creates lots of inertia in the system. When we started this process, we actually started implementing the protocol within inpatients. So patients that would normally never have qualified for arthroplasty outpatient surgery. But we started practicing, for lack of a better word, by putting them on the protocol as inpatients and trying to work through some of the issues that were occurring with maybe the wording or the dosing and so forth. And through that process, we streamed it down to something that was completely presentable. And that's when we started booking patients for same-day arthroplasty. And even then, for the first 4 patients, we actually admitted them as same-day arthroplasty. They followed the protocol completely, but we still admitted them with a hands-off approach from nursing, and unless they needed it. And the reason we did that, because we realized that at this stage of the game, we needed to keep momentum. And the worst thing that could have happened at that stage was having some failures or mishaps that we didn't recognize. And that would have really kiboshed the whole process, and we would have lost so much momentum. And even when we started sending patients home in the first few, we set up for fallback. We would have callback numbers. We had orthopedic on call, notified emergency, etc. So, and we had multiple phone calls post-op. And all this gave us enough confidence to start believing in the process and also leading to success. And I promise you, when you get success, it is truly invigorating. And when you create success, that truly drives change. And I saw this firsthand in our institution. Even the most reticent anesthesiologists, there are people who are staunch 15 milligram bupivacaine isobaric users. Even they came to me in the corridor and said, well, what are you doing there? Why is that working? And the nurses start talking, the physios start talking, they start asking you, what are you doing different? And everybody becomes a little more interested in the process, and they become interested in change. And I found that once administration wakes up to the fact that this is a massive cost-saving venture, it really gets a lot of steam. And obviously, there's unique institutional barriers that you have to overcome and work through. And as I mentioned earlier, understand your matrix. But the obvious anesthesia barriers, and I saw some of these come up, are the neuraxial techniques and dosing and drugs, and then sedation techniques. And I think also being comfortable with the oral pharmacokinetics of drugs. Changing people's perception to neuraxial anesthesia is very hard. There's a few things, and they go hand in hand with the whole sedation protocols as well that were mentioned up front. The first thing is avoidance of neuraxial opioids. And I think maybe most people have already switched, but a few years ago, we were all using Epimorph for patients. And what made the big change is I decided to insist that all knee replacements go on the acute pain service. And by doing that, we all do our own pain, well, not our own pains, we provide pain service rounds as a group. And nothing works change more than, or creates change more than success, as I mentioned earlier, but seeing your own complications, such as urine retention and significant vomiting. And in 2 months, we stopped using Epimorph completely. The next point is dosing of spinals and this concept of epidurals that are not fully motor blocked. And this really falls into the whole sedation practices as well. People are often uncomfortable with doing deep IV sedation or GAWA, as some people propose. And I think this is the most important part of Champion and trying to change the goals. There's two things. I do reassure my colleagues all the time that it's so well within our practice to provide general anesthesia or convert to general anesthesia, and also to provide deep sedation. That is what we do, and that is okay. And I think that we have to try to change our focus away from this concept of failure, this failure of conversion to a general anesthetic is a sign of some form of failure. We've been taught to focus on the intraoperative management so well, and we've done such a good job of doing that. And I think that we've forgotten the goals of the post-operative care. And I think that we should be focusing on both those aspects equally. And I think we need to be part of the goals of the post-operative care. And that includes low-dose spinals or epidural analgesia as proposed. And if that means that we have to run these patients deeper during their sedation, then we are actually contributing to their perioperative outcomes rather than meeting our own intraoperative goals. And I really propose this bias or this ego failure of intraoperative conversion that really has to change from an institutional practice. And then I think just some issues of wisdom, maybe I called it, maybe it's not, but when we started, there is this, when you start implementing these kind of protocols, this same day protocol, you might feel lonely at first because you do feel like you're going a little bit against this norm of deep sedation, maybe maybe the patient's moving a little bit or that, and it just feels like people look at you a bit strange. And I think that if you do feel that way, reach out to people who are doing it, like myself or one of the other members of this panel, because it's okay. It does feel a bit weird. And then I think it's really important to invite critique from all sources, because it really gives you the opportunity to pitch your brand. It gives you the opportunity to discuss what you're doing at the time and educate and work through the process with individuals. And that forces change. I've seen it firsthand. I think it's important to invite critique also, because I think a lot of people may have situational awareness that you overlooked that maybe even imply patient safety. So in summary, I think implementing and overcoming barriers really means that we just need to lead the change. And when you create success, you certainly create change. I've seen it firsthand. And then celebrate success. Make the banners, write the poster, scream it to the hills, because this advertisement really just drives change. People love to see a success, but they also want to be part of it. And people don't want to be left out. And we saw people coming to, I see my colleagues coming now and saying, yeah, you know what, it's kind of fun. And I think to involve our colleagues in the objective outcomes, and I don't mean doing functional research because we don't have the resources to do all those things, but getting them involved in seeing outcomes firsthand and being part of that data collection maybe, or even just anecdotally being part of those objective outcomes, I think really creates change very effectively. And then finally, I think patients, this process takes time. And I think that it takes longer than you expect. But I think for me, I'm very grateful for this opportunity to have been involved in this process, and it continues to evolve. And I think that it's changed my perception of a very boring, mundane day in the joint replacement room to something that is actually totally invigorating, and it's been very satisfying from every perspective. Thank you.
Thank you very much, Jacques. So first of all, thank you to our 4 panelists for this, for sharing their knowledge, their experience. We had a lot of questions, very insightful questions, and I noticed that, you know, some of them were answered by our panelists as we went along. So I would ask Pascal, if you want, maybe just to summarize the most important items that you have, most important question that you, most relevant that you have answered. And also I want everybody to be reassured that the list of questions with the answer that are in the chat box will be forwarded to you. So you no risk with that. But in the meantime, Pascal, a few words on the questions you have answered.
Yes, first, I'm really sorry because I was trying to answer all the questions one by one throughout the webinar, but I was sending all the answer to Claude, who knows all the answers. So, so most of the question are really related to a change in tradition. What's presented tonight is really something new, something different that is quite disturbing for the current practice. It is not the gold standard practice across Canada. And most of the question was regarding, oh, this is something different. Is it risky? Is there a problem with the dosage? Or so we totally understand that there is a learning curve if you want to implement such a protocol in your practice. And the basis of the webinar tonight was trying to explain, you know, the experience. When we started with Christian, it took him maybe 2-3 cases to get really the fine tuning of the technique, but I can assure you that most anesthetists in our center, after a few cases, they really manage well the technique. And one of the key feature, you know, many comments were regarding why doing all these interventions. Why should we take the time to do the epidural, do the propofol sedation, and be fine-tune all the dosage? I think this is for patient well-being. We want to improve patient satisfaction. We want to speed up their recovery. And really, what we want to share with you, what I tried during my talk, is that the anesthetic technique that we presented you has an impact on the patient post-op recovery. And for sure, we need some science. And I would suggest any anesthetist that is on the webinar, if they're willing to do a RCT comparing this combined anesthetic technique with a modern spinal, that would be the best study to be done right now. And for assessing the post-op recovery of the patient, not the pain in the first 8 hours, but what the patient do after 1 week, 2 weeks, 3 weeks, how he can walk, how he can climb stairs. This is very important for the orthopedic patient.
Thank you very much, Pascal. And we have a question that is very orthopedic directed. So I will ask this before I go and talk to my anesthesia colleagues. So does the approach matter, anterior versus posterior? And also we can put into this, under this umbrella, the surgical techniques has evolved. It's less and less invasive, protect muscles. So is there any specific technique where an outpatient may not be done? So just having your general approach for surgery would be appreciated, Pascal.
Yes, we are 4 surgeons who do hip and knee replacement at Maisonneuve-Rosemont, and we all do posterior approach for total hip. So when we decide to implement an outpatient ERAS protocol, if you look on the internet, you look at all the advertisement, people tend to say that outpatient surgery can only be done with direct anterior approach. And we wanted to prove that the surgical approach has no impact on the result of the outpatient ERAS protocol. And that's what we showed in our study. I mean the most important is the ERAS interventions that you do that will change the patient recovery. And yes, we don't do a 20 centimeter length incision. We shortened our incision in the last 10 years in orthopedic surgery, and our surgical time is around 1 hour. So I mean, the best is to know your surgeon if you're in your team to adjust the technique you're using to make sure that the best care is provided to the patient.
Thank you. And a question for my anesthesia colleagues is, could you please comment on the epidural proposed versus a mepivacaine spinal?
We don't have much experience with the mepivacaine. I know it's a short-acting medication. It needs to be tested, tried, I guess, see what is the outcome again. Nice thing about the lidocaine is that it doesn't last very long either. So the patient, we know that with lidocaine, the patients at the recovery unit, they are moving their legs and they walk about an hour after the surgery. So maybe there is room for mepivacaine. But I don't have much more to say beside that. If you decide to use mepivacaine, make sure that you measure what you're doing, you're measuring the outcome, and your patient are as satisfied globally. But I have no more experience than that with mepivacaine. As for bupivacaine, I saw someone saying, talking about bupivacaine. I would not recommend bupivacaine for epidurals for many reasons. One being that it's a very long-acting local anesthetic. I would not use that for rapid recovery. That's for sure.
Okay, and do we have experience with the abductor canal catheter for knee arthroplasty? Is this something that should be part of the protocol, Avi?
Well, could I just, I think the concerns about epidural versus spinal are very, very concern. It's a big concern, and it's the major question most anesthetists will ask. And just to clarify, from a surgical point of view, I don't want to speak for Pascal, but I know my surgeons we were expecting there to be less of a global dense laxity in the joint that I'm sure would make the surgery easier, but I can't speak to that. And yes, there is a subtle difference in the surgical conditions for which the surgeon has to be prepared. Again, what I proposed to my surgeon, and he agreed and acknowledged that as a benefit to the patient. And so, again, I won't speak any more about surgical technique, but I would like to share my screen regarding the question about epidurals, because there is, I mean, I trawled the literature for evidence, and the Mayo Clinic or clinics such as Mayo and Cleveland do large number analyses. And this slide I'm just sharing looks at length of stay is better with neuraxial than even general anesthesia. So you would think a bookended surgical technique, anesthesia technique, where you can start and stop it would be better. But in this case, they're providing data to suggest the neuraxial is better. Then teasing between the neuraxial and epispinal and epidural, I was quite interested to see this forest plot to say that the epidural was better than the spinal. Now, I think we can all reflect on our own experience, and in the days when the dose of spinal that I gave, I expected to run out or last a certain time, and it lingered. It just lingers. And it lingers in such a way that the anesthesia descends to resolution, and it descends towards the feet. And that is a problem if you want to put the patient on those feet, because their proprioception comes at last in the soles of their feet. With the epidural, simplistically, it is a segmental block that recedes upwards. So the first thing to recover are the lower limbs. And as the videos shown by HMR, Hôpital Maison Malheureusement, were evident that the patient's lower limb motor function was preserved even during the surgery to some degree. And so the recovery was first in the area where you want there to be recovery. And so simplistically, that's the explanation I came up with, trying to explain this whole thing to non-medical colleagues. Also, the dose of the epidural is something that we need to be aware of. The dosing of our epidural, of our spinals, it's excessive. It's frankly excessive. And there's fairly good data looking at bupivacaine in this case, where the median dose required was 5 milligrams. Another one looking at mepivacaine, which has come up in the conversations. Sorry, bupivacaine versus ropivacaine. Again, the median doses are extremely low. And another one I have here for mepivacaine is again showing doses that show recovery much faster with mepivacaine versus the others. So mepivacaine is a good choice. I think the issue here is dosing. And if I just stop sharing that, I'll return to the group. I think epidurals are predictable. You can dose them. I think another question came up saying, what if there's a surgical problem? Well, that's simply, the fact is that you've got an epidural. You just keep redosing it. The problem would arise and you'd have to convert if it was a spinal. So our comfort with spinals perhaps is misplaced, and the titratability of the epidural is greater. If you want
I'd like to add to Avi's comments there as well, just from our local experience, same thing. The epidurals are extremely predictable with their offset, where the spinals are completely unpredictable. Even age, size, and weight, it doesn't make a difference. You just can't predict it. And then the thing that we haven't really touched on a lot is post-operative urine retention, particularly in male patients. We're not seeing any with epidurals. We have zero. And I've got a small series, which is really small, but of 10 patients that had previous joint replacements with post-operative urine retention. And their subsequent joint was done on epidural and protocol, and have no urine retention issues. And then finally, the orthostatic hypertension, which no one can really physiologically explain, but there seems to be a residual sympathectomy that lasts more or longer after spinal anesthesia, or particularly bupivacaine spinal anesthesia, and it doesn't seem to be occurring with the lidocaine epidurals. And so we've had zero orthostatic hypotension, which is a common phenomenon after spinal anesthesia. And then finally, just that slide that Avi showed about the mepivacaine spinals. If you look at that paper, they actually had multiple failures of discharging patients in the mepivacaine group, and both groups. And it was due to orthostatic hypertension and urine retention.
Perfect. Thank you very much. So in the interest of time, I would just ask participants if you have more questions or if you have topics related to this protocol that you would like to be discussed in the future, please write it in the chat box and we will follow up. And again, you will receive all of these questions and answers. Any last comments from our panelists?
If you want, I have slides on adductor canal, and it would be, I think, a useful thing to discuss because we've pretty much stayed on hips, not knees, and there's been questions. But
we definitely can allow this.
If you have time, yeah.
Yeah, please go ahead, Ivy.
Okay, so the ERAS protocols coming out of Europe do not use regional anesthesia, and they rely very heavily on local anesthetic infiltration by the surgeon. And as I mentioned in my brief talk, the infiltration has to be accurate and precise and well placed, and generally a very large volume. And we went through a learning curve for that with hips. We don't quite have the confidence with knees yet to do that. And again, with adductor canals, it's a contentious area, whereas with some good data published by colleagues, particularly in Ottawa, where they looked at proximal versus distal and femoral triangle versus distal canal. And the proximal or the femoral triangle, if that's can be described in this slide here, was as effective for preserving motor power in the quads, but more effective for pain. Again, this is a learning curve that we're all going through. And it is, I also sort of tend to advocate adding the obturator, but if our infiltration technique was optimal, perhaps we could avoid using blocks, but our surgeons do quite like the peripheral nerve block catheters and baby bottle programs that we have that provide 2 or 3 days of this technique. So they want us to continue, and I have offered them to do single shots or rely on infiltration. But again, their learning curve for the infiltration pattern and quality and volume is evolving. So we're all evolving in this.
Perfect.
I can just sort of chip in quickly about the regional part of. I see there's another question about paying blocks. Unfortunately, once we start bringing in more surgeons into the program, the quality of local infiltration is very variable. And so people are less motivated to get the local anesthetic and the high volume local anesthetic into the right places. It becomes a little bit less predictable maybe. And so we reserve regional anesthesia for patients who are failing in the recovery room. And if, because the lidocaine is extremely fleeting, it will disappear extremely fast. So the lidocaine epidural, and so the patients, if they're going to have pain, if their multimodal is not quite, or the local infiltration is not quite covering it, then we will resort to doing adductor canal blocks, or and sometimes ping blocks. But I must be honest, it's rarely needed in hip replacements. But I think that has got to do with proper placement of periarticular infiltration.
Perfect, thank you.
If I can add just a point regarding the blocks, it was a decision we had to take when we implement the protocol. And we thought that the ERAS principle, the basis was to simplify post-op care, to allow the patient to be able to walk freely with full motor function without any catheter, big dressing, and to make them as return to their normal life as possible. So we decided not to use a peripheral block, continuous peripheral block, because we wanted the patient to be able to walk, to go home. So they don't go home in a wheelchair. They want to walk with a cane, as you saw. They don't carry any catheter, any IV, anything with them. So we don't want to transfer hospital work to their home. We want them to go home as autonomous as they can be if they would have stayed 3, 4, 5 days in hospital. So this was the basis of not using a peripheral continuous block in our patient.
Perfect. So that concludes very well. Thank you, Pascal. Nice conclusion. And so just expect to receive these pathways, the tools for patient education prior to surgery. And also we're working on a supportive video for when patients go home with some physiotherapy exercise and key messages that they have to hear. And again, when it's addressed to patient, it's in French or in English, and the video that is in English is subtitled in more than 20 languages. So I think your patient will feel quite supported even after surgery. So thank you very much for your attention, and thanks again to our 4 panelists that were outstanding. Have a good evening, everybody.
Thank you very much. Have a good night.
Thank you.
Thank you. Have a good night.